Thank you very much, and thank you, Stephen, for that very flattering and not at all rambling introduction. I have to thank you. It is such a great privilege to join you for the first BC Quality Forum, and I thank Christina and her team for inviting me. It really is a treat. Vancouver is lovely. Take a look at this. I'd like to ask two questions. Let's think about these two things for the next hour or so. What could this place and this place possibly have in common? And why does this dancer impress us, but these dancers consistently get a standing ovation? So I want to be frank with you. It is the afternoon of the second day of a very intense conference. We just had a really nice lunch. I was planning to zone out for this. But now that I've seen those pictures and heard those questions, I'm sort of intrigued by what I might have to say. I have my full attention. I hope you'll join me. I'd like to think with you a little bit about some of our adventures, and I just have stories to tell you today. I don't have anything to teach you. I'd like to think a little bit about some of my own adventures and discoveries about clinical variation in my practice and how it's led me to dig a little deeper into it. And I'd like to think about three questions or possibly demonstrate to you three things. First of all, clinical variation in practice is very, very common, and I'll even say it's pervasive. The second thing I'd like to try to show you is we don't even realize how much clinical variation is out there. And most importantly, I'd like to share with you the problems that it causes, the defects that it causes, and the way it affects the way that we can deliver quality care for our patients. So this first picture that I'm showing you is Saskatoon in December. And I spent the first half of last December here. This is my home. And if you look off to the right, you can see my office, and I'm waving at you from one of the windows. But I enjoyed spending the second half of December in Maui. And what could they possibly have in common? I mean, they're in different countries. They're 5,000 miles apart. Apart from the climate, one is in the middle of a continent as far away from an ocean as you can be, and the other one is an island. One is one of the most sought-after tourist destinations in the world, and the other one is in Hawaii. So what do they have in common? They have this in common. So just in case you aren't familiar with Costco, Costco is a bulk warehouse where you can go to buy a lot of anything. And while we were on holiday in Hawaii, we need a lot of some stuff. And so we went into Costco. And we went in the front door of Costco and saw this. We saw a whole bunch of big screen TV sets. And my 14-year-old son said, "Hey, cool, this is just like in Saskatoon. Around the corner must be watches and jewelry." And so to test his hypothesis, he went running around the corner. And he was right. And he was pretty thrilled with this, that we had come 5,000 kilometers across the ocean. We were in Hawaii, yet he knew what to expect. He went in the door of Costco, and he knew where everything would be. Somehow Costco had given him a consistent and predictable experience and helped him navigate his way through his shopping experience. Pretty impressive. I will admit, though, that the surfboard selection in the Maui Costco was a little better than in Saskatoon. I'll admit that to you. I recently found out that I, in my practice, don't do as good a job as Costco does. And about 2 months ago, the wife of a patient told me off. And her timing, I thought, was unusual and perhaps a little bit daring. She chose to tell me off as I was about to operate on her husband. So we were in the pre-op area, in the OR, And I was just going over the surgery that her husband was about to have. And I mentioned that his hospital stay would be 1 or 2 days. And she got upset. And she said, well, which one is it? You're telling me 1 or 2 days. The nurse who we just spoke with said it would be 2 or 3 days. And this pamphlet, she waved it in my face, says he's going to stay 4 or 5 days. And I took the pamphlet and I looked at it, and all the information about the surgery was correct, but it said 4 or 5 days. And I realized that that pamphlet she had been given was reflecting practice from about 5 years ago. And so I assured her that I thought my estimate was correct. We went ahead with the surgery. A week later, I called the man up to see how he was doing and to give him his pathology report. And I asked to speak with his wife. And I told her, you know, you brought that pamphlet to my attention, and thank you very much for doing that. I've spoken to our nurse educator, and she's fixed the pamphlet. I'm sorry that you saw that. But I'm really curious why you were so upset, because it was a minor issue. 4 or 5 days, 1 or 2 days, I give you the right information. And she told me that the reason she was upset was because she thought it was a sign that we in the hospital weren't talking to each other. She said she was worried that if one of us couldn't talk to the other one and decide what she should be told about her husband's hospital stay, how were we going to talk after he had his surgery? What if he got sick? How were we going to communicate? And that little thing that I thought was totally insignificant shook her confidence in our system. So she had extrapolated from that we weren't fit, possibly, to look after her husband. So that was a very telling moment. Can I just ask the gentleman in the AV crew to start my clock, please? So that was a lesson to me that variation in practice leads to a loss of confidence. As part of our office work, and Stephen referred to my practice group, who I'll introduce you to in just a minute, we have several initiatives going on to improve our care. And the latest one we've been working on is to try to improve care for patients with bladder cancer. And as part of exploration of how we could go about that, I've been talking to different people who are part of the system. And the first person I went to talk to was my office manager. And I asked, you know, we want to do a better job of how we're providing bladder cancer care. Do you have any suggestions? Without a pause, the first thing that she said was, could you guys get your act together with BCG treatment? BCG is a very common chemotherapy used to prevent bladder cancer. And she said, you guys are all over the board with this. We can't keep track of it. And I was a bit puzzled because to me, there's only one way to give BCG, and that's the way I do it. So I didn't see any variation. And we sat across my desk from each other for a couple of minutes, and she gave me a look. And if you knew her, you'd know what that look meant. And it meant, think about it a little bit, doctor. So I did think about it. And I said, so I'm doing it one way, and the other 7 urologists are doing it their own way. Is that right? Bingo. So my office staff was trying to figure out 8 different ways of giving this very common treatment. And we all have our own little twist on it. And they found it very confusing because they found it difficult to schedule appointments and counsel patients on when things would happen. Then I went over and talked to the nurses in the treatment center who give this medication to our patients. And they, to paraphrase them, they were slightly more polite than my office manager, but to paraphrase them, they said, could you please, doctors, get your act together? Because when patients come to see us, they trust us to give information about this treatment and what to expect. But we know there's 8 different ways to do it, and we have to be really careful what we say because we don't want to contradict what you've just said to your patient, because we know that'll erode trust in our patients. So could you come up with one way of doing it? And I thought I was onto something, so finally I went to speak to the cancer clinic pharmacist. Same message. They're having to mix up this medication, figure out the dosages, and there's 8 different ways to do it. And I didn't even realize that we were so far off the map. So variation breeds confusion. That's waste. That's extra work, it's rework. So now, as promised, I want to introduce you to a group of people who it's been my privilege to work with for the last 20 years. Saskatoon Urology Associates, an amazing group of physicians. And over the last 5 or 6 years, we've had a concerted effort to improve our processes. We started off, as Stephen alluded to when he mentioned that we have a blog about our work, we started off with advanced access, trying to improve access for our patients. But since then, we've moved into a lot of different areas. And we've come across a lot of things that really surprised us. So there's 8 of us that work together, and we like to think that we have a real homogeneous practice. So we will look after each other's patients when we're away on holiday. If one of my patients needs surgery and I'm away here today, yet one of my other partners can do it today, he'll look after that. So we like to think we have a really homogeneous practice. At least we flattered ourselves that we were homogeneous until we started measuring things. And curse you, data, for interfering with my very convenient preconception. Because we thought we had a very level way of doing things. But I want to tell you what this data shows us. As we were trying to improve access for patients, we realized that we were taking up a lot of capacity. So internal recall refers to how often I have my patients come back to see me. If Mr. Smith comes and sees me with an enlarged prostate, I might have him come back and see me every 3 months. But my partner may have Mr. Smith come back every year, and my third partner may not recall Mr. Smith at all. He may tell the family doctor to look after things. So we started measuring our recall rate because we realized if we're doing a lot of recalls, that's taking up a lot of capacity where other patients could be seen. And look at the difference in our practice. On the far left side, you can see that one of the urologists recalls almost a quarter of his patients. Come back and see me again. Come back and see me again. Whereas on the other side, on the right side, you can see one of the other partners barely recalls any patients. And then everybody else is sort of spread out in the middle. Any suggestions on what's going on there? Anyone want to shout out any explanations why there's this big difference among the urologists? Subspecialties? At this point, only one of us had a subspecialty. One of us does pediatric urology, and he's right in the middle. So that's what we thought too. But it turned out not to be the case. Great suggestion. Can I take one more thought? Higher acuity patients. So maybe some of us are seeing sicker patients, cancer patients. Maybe some of us are doing a lot of outpatient practice. But that turned out not to be the case either. Sorry? So some great thoughts. Do we trust family physicians to follow our patients? Lots of great ideas. Some other ideas we came up with was perhaps this has to do with the age of the physician, how long they've been in practice, their confidence. Well, on the right side, physician B was the youngest physician in our practice. Physician A was the senior physician. And the high recalling physician, physician C, was sort of in his mid-career. So we were curious, why is this happening? And we sat down and talked about it, and after we hashed it out, we found out the reason for this variation was just because. There was no reason. It's just because. That's the way we were trained, and that's the way we had fallen into our practice. There was no reason for this variation. But what we did realize was variation was wasting our resources. Variation was taking up capacity where we could see new patients. Now, just in case you think Saskatoon is an anomaly, and that's the only place that there's a lot of variation, let me introduce you to someone who is the thought leader in variation in healthcare, Jack Wenberg. You may be familiar with the Dartmouth Atlas Project. So over the last few decades, Dr. Wenberg has been collecting Medicare information across the US and tracking variation in practices. So look at this jigsaw puzzle of a map of the United States. The different colors represent different rates of, in this case, mastectomy for breast cancer. And quite literally, it's all over the map. So he's done a lot of investigation into why this is the case. Here's some other specific urology examples that Dr. Wenberg has come up with. The variation in the rate of a surgery for benign prostate enlargement varies from 9.5 to 1.7 per thousand. just in different parts of the country. Surgery for prostate cancer varies up to 12 times different in different parts of the country. How can it be that there's that much variation? Who's right and who's wrong? Because they can't both be right. Well, you might be saying, that's in the United States and they do things differently there, and there's a lot of different motivations. The system is different. Let me bring you back to Canada. Let me bring you back to Saskatchewan. And I purposely show this map because for many of you, you've only seen Saskatchewan from 30,000 feet. I know. You get on the plane, you're flying to Toronto, and you just hope, I hope there's no engine trouble. And if there is, can we just glide all the way to Manitoba? I get it. But I also wanted to show you that this is the way you draw a map. 4 straight lines. You guys have got a mess. Have you looked at it? The right side of your map, I think we could fix. I think we could lean that. The left side, total transformation. It's a mess. So here's Saskatchewan. And we found out a few years ago that there was a wide discrepancy in how prostate cancer was being treated in Saskatchewan. Really 2 options for prostate cancer, surgery or radiation. And in Saskatchewan, we traditionally draw a line across the province, not in the geographic center, but in the population center. So north of that blue line would be Saskatoon's usual referral area. South of that line would be Regina's usual referral area. And look at the difference. If you're a man with prostate cancer and you live south of that dividing line, you're twice as likely to have surgery for your prostate cancer than have radiation. So twice as likely south as compared with north. How could that be? It certainly can't be accounted for by different conditions because the type of cancers are very homogeneous. Certainly the patient population is quite homogeneous in Saskatchewan. So that has made us curious. And more broadly, if you looked at the Canadian Medical Association journal last month, you would have seen this paper from Ontario, which compares hospitals providing cardiac intervention. And look at the discrepancy in rates of percutaneous cardiac intervention, angioplasty, stent insertion, versus coronary artery bypass grafting. It's a ratio of 4 times. What could account for that variation? Which patients are getting the appropriate treatment? So variation in practice indicates that there's probably some inappropriate care. It doesn't tell us which is right. It doesn't tell us is percutaneous intervention and stenting right, or is a CABG right, but it tells us we need to think about it and be curious about it. Here's Dean again. Now at this point, and you can see what's about to happen to Dean. At this point, some of you may be feeling like Dean. So you're Dean, and I'm the pigeon. You may feel that I've just on your heads by showing you, quite frankly, what a bad job we're doing. How much variation we're presenting to our patients and how it's interfering with good quality care, how it's wasting resources, and how it often means inappropriate care and how it's sapping trust in our system. Well, don't despair, because the rest of my message is how we can improve things, how we can make things better. So I want to think about how we can reduce variation in clinical practice. But specifically, how do we reduce unwanted variation? Because some variation is good. In fact, some variation is mandatory. Even more than that, it's a clinician's job to make sure that there's appropriate variation that suits our unique patient. So we may have good clinical guidelines for someone with diabetes, but then when someone has diabetes and hypertension and a brain tumor, those guidelines may not be appropriate, and that's where clinicians have to bring in variation. So unwanted variation we want to get rid of. Back to Dr. Wenberg, our thought leader in clinical variation. So Dr. Wenberg talks about 4 different sources of variation. 2 are good, 2 are unacceptable. The first one he talks about that's unacceptable is variation related to system factors. For example, in Saskatchewan, we don't have a PET scanner, a way to detect metastatic cancer. So patients have to travel outside the province to have it done. So our utilization of PET scanning is going to be very low compared to other provinces. So that's probably not a good source of variation. That's related to the system. Provider variation. I've mentioned prostate cancer a few times. Well, there's many studies that show if a man goes to see a radiation specialist and a urologist, that man is going to get very different advice from those two specialists. Urologists, surgeons, tend to recommend surgery. Radiation oncologists tend to be equivocal. They're not quite sure whether surgery or radiation is the best, but the advice men will get will be very different. So Dr. Wenberg tells us that that's related to provider variation, and that's not acceptable. He does tell us, though, that disease processes are different. If you had low-grade prostate cancer or high-grade prostate cancer, if you had diabetes alone or diabetes, hypertension, and a brain tumor, then yes, it's important to bring variation in so that you can satisfy the unique needs of that patient. And finally, and most importantly, and most powerfully, patient preference is important. So if we're equivocal about the results of a medical treatment, then it's so important that patient's preference, and that's a well-informed and educated patient, should hold sway. And I want to show you some of the ways that in our practice we've been trying to remedy some of this variation. So first of all, back to our surprising revelation that we have this huge variation in how we recall patients. And as I said, we sat down and thought about what could be the possible reason, and there wasn't one. It's just that's the way we do it. And we had never spoken about this before. If you know surgeons, you know that surgeons love to tell war stories about the OR. That's fascinating. Come up to the OR lounge sometime and just listen to what we're talking about. Oh, I tore off a renal vein today, and I had to pack this and clamp this, and everybody's riveted because they know it might happen to them next week, and they want to find out what you did, what worked, and what didn't work. But if I sit down with my partners and say, hey, I recalled somebody who had an enlarged prostate today, it's pretty quiet. So we had never discussed what our office recall practices were. But once we had identified these variations, we started talking about it. And we started saying, well, do you recall people with kidney stones? If someone has bladder infections, do you make them come back and see you again? And if the answers were different, how do you manage your practice? And we started realizing that there were ways to give patients better care, make sure that they were still getting the care that they needed, yet they didn't have to come in and see the urologist. For example, I might take someone's kidney out for a kidney cancer. My traditional approach had been, come back and see me every 6 months. I'll examine you and do an x-ray. Whereas one of my partners had developed a follow-up algorithm that really looks just like an oil change sheet. In 6 months you have this, in 12 months you have this. And so we all adopted that and started giving it to our patients and sending it out to family doctors, just as an example of how we could change our practice and repatriate patients to their family doctor and reduce recalls. Now, also, my bent, being a surgeon, was I wanted to take control of this. And so I looked at this information and I said, you know, about 17% looks to be the average here. We should draw a line across there and say none of us are going to recall more than 17% of patients. And that seemed totally fair for me because that was a nice average. And the feedback I got from my partners, and I'm going to say feedback because it's a polite audience, but the feedback I got was, oh, so what's your evidence for 17% recalls? Well, there's no evidence. Of course there's no evidence. Well, how do you know that if you only recall 17%, you're not giving good care? Oh, well, I didn't think about that. I had just presumed that the doctors who were recalling a lot of patients were in the wrong, and the doctors who barely recalled any patients were in the right. I hadn't even thought about the fact that maybe the low recall doctors were giving poor care because they weren't giving the special attention that patients with cancer and other serious conditions need. So my learning from that was, this data should only provoke conversation. It should stimulate curiosity. This is not data for judgment. Another initiative that we're working on in Saskatchewan is the Saskatchewan Surgical Initiative. Here's a bold promise. By April 2014, all patients booked for surgery in Saskatchewan will be offered a surgical date within 3 months of being booked. Wow, we're 2 years into that initiative. I think we're going to do it. But the journey has showed us that it's not enough just to get the wait times down. We need to be giving appropriate care. And a big part of appropriate care is patient choice. So, we're trying to give information to patients in a way they can use it. This is a screenshot that shows some of my wait times, but every surgeon in the province is on this online tool, and it's available to the general public, and most importantly, to family physicians who will be counseling their patients. So if someone wants to know, I'd like to get my hip replaced, who has the quickest time, who has the shortest waiting list, they can go on and find out which physician has that. Previously, patients never had access to that. Maybe if they knew somebody who was the secretary of the orthopedic surgeon, they could get that information in secret, but otherwise, there was no way to know that. So giving patients the information gives them a lot of power. Just so you don't think you're being left out, British Columbia has a very, very similar tool, and it's available online for you as well. Getting back to the prostate cancer surgery discrepancy, this got a lot of attention at the level of the Ministry of Health in Saskatchewan. And they started asking questions, how can we have this big difference? And they started going down the road of saying, we need to set some limits on this, very much how I wanted to set limits on my partner's recalls. And we talked about that a little bit and said, maybe we should look at why there's a difference and try to address that first. And we felt the difference was in the information men were receiving, the education they were getting around the options for prostate cancer. It's a very complex discussion. It often takes me 45 to 60 minutes sitting down one-on-one with a man to go through all the different options. So we've been developing teaching options for men. We have a very comprehensive website that walks men through the decision-making process. It's extremely well received. Men are really thrilled with it. It's a very interactive process. And we hope that's going to, at least if it doesn't shift the rate of surgery versus radiation treatment, men will at least be making those decisions for the right reasons. I want to introduce you also to a secret weapon. This young lady is Nicole, and she is our urology nurse navigator. About 2 years ago, we got funding for this position, and you'll be familiar with the navigator position in breast cancer and other cancer areas where one single contact, usually a specially trained nurse, guides a patient through the process. And over the last year, Nicole has been shadowing the urologists. And I mentioned I'll sometimes spend an hour sitting down with a man and his family talking about prostate cancer. And she would sit in on those discussions. And eventually she said, I've sat in on these discussions with all 8 of you urologists in Saskatoon. And did you know you all give a different talk? We had no idea. Very much like the bladder cancer treatments, we had no idea. And wouldn't it be interesting if we gave the same talk to men and see if that changes their decisions? So over the course of several months, Nicole sat in with each of us and took extensive notes. And she got to the point where she thought she could give this 60-minute talk. Well, if you're a specialist who's trained for years and years and has been in practice for 20 years, for someone to say, I think I can give that talk after a few months of listening to you, I'm not so sure about that. So we decided to try it. And we switched chairs. So Nicole took the big chair, and I sat over in the corner, and she gave the talk. And I was there for backup. Didn't need to back her up. So just by listening to us, she had put together her own synthesis of the information, and she could now give the talk. So she did this with each of the urologists until we were all comfortable that she could do it, and now she does it independently. And she's very tactful about it. When she talks about how she put the information together, she says, I went and listened to all 8 urologists, and many of them had things to say that I incorporated in the talk that I gave. Some of them had things to say that I've chosen not to incorporate. And she leaves it at that. And so now, not only do men get a consistent, standardized piece of information, it's also freed up the urologist's time to see new patients. So this has been a really fabulous way to standardize our processes. Now, so far, the clinicians in the room have been the ones wearing the pigeon hat. Okay? I know that everything that I've said today has been pretty critical about our clinical processes. And I suspect that some of the administrators, the managers, directors, vice presidents, CEOs, quality improvement people are feeling a little bit smug because you don't have anything to do with this. Well, this is your part. Time to put on the pigeon hat, because variation is a symptom. It's not the disease. Which brings me then to the second question I posed to you at the beginning of this talk. Why is it that we're impressed with this dancer? This dancer is exhibiting virtuosity. We are so impressed with the work, the time, the dedication, the discipline that's gone into executing this grand jeté. Yet, these dancers, the Rockettes chorus line, are performing high kicks, which, let's say, is at best a little pedestrian, but they consistently get a standing ovation. What impresses us about them? Because we know that even though each individual performance may not be virtuoso, it required a lot of effort to make them work as a team, to execute in a synchronized fashion. That's what impresses us here. Any parallels? How about my work life? How about the surgeon who has individually dedicated him or herself to expertise in their craft, to virtuosity? How many times do we sing the praise of the surgeon, yet ignore the team that has to work together to let that surgeon practice his or her craft? And I mean the OR team, the OR nurses, the clerk at the front desk, the people cleaning the floors, the people stocking the instrument carts. How often do we celebrate that? But it's very impressive when the system works well together. And so now to the administrators in the room. Variation is not the disease. It's a symptom of a poorly functioning system. And that is your task. It's your task to make the system work better so that we clinicians can do a better job of providing consistent and reliable care to our patients and clients. How are you going to do that? Well, I think you'll have to make sure that you give us the data. Those charts that I showed you with the variation in our office are the results of painstaking manual collection of data by my staff. And that's the way it is in our whole health region. So you can help us by making sure that we have real-time data that we can use. You can help us by providing time so that we can get together away from our clinical duties to have these discussions. And you can make sure that you facilitate those discussions so they don't turn out to be judgmental, so they turn out to be an exploration of curiosity. And most importantly, don't try to impose a solution on us from up above, because we'll push back hard. Let us be curious. Let us explore. We'll come up with the solutions because we want to make sure that we serve our patients well. If you spend time hanging around quality improvement circles, you're bound to hear this. What can we do by next Tuesday? You've heard that. And I always find that a little intimidating because it always seems like you've got to come up with something amazing and on short notice. I can, world peace, I guess. I'm not going to do that to you. So let's not say, what can you do by next Tuesday? Let's think more, it's a play date. And so I'll give you this that you could play with by next Tuesday. I'll give you two options. The first one is, go out and be curious. Go and talk to someone in your area, whether it's an administrative area or a clinical area, and ask them. You know, we listened to this guy talking about variation. How do you do this? I'm curious. Is there a different way you do this? If you're a nurse on the ward, say, what do you take in for a dressing tray? What stuff do you have versus what I have? If you're an administrator, you know, how do you set up this spreadsheet for the budget? You know, you seem to do that a lot quicker than me. And be curious. If you don't want to talk to them in person, send out a little survey monkey online and just find out. Look at the variation that's going on and let that spur your curiosity. The second option I'll give you is what I'd like to leave you in closing. And if you're ever giving a presentation on quality improvement and you're unsure how to finish, your default position should always be a quote from Don Berwick. You can never go wrong. And for the one or two of you in the room who don't recognize the name, Don Berwick is the founding CEO of the Institute for Healthcare Improvement and a visionary genius. And so if you have something to quote from him, I think you'll always do well. Before I show you the quote that I'd like to share with you, I want to thank you again for inviting me. It's been a tremendous privilege to be part of this inaugural Quality Summit. I would also like to invite you to Saskatchewan's Quality Summit, which takes place next month, April 17th and 18th, in Saskatoon, because the opportunity to come here and hear from you and share with you has been brilliant, and maybe we could do the same thing in Saskatoon. So what I'd like to share with you is this. Variation is a thief. It robs from processes, products, and services the qualities they are intended to have. Unintended variation is stealing healthcare blind today. If we could address unintended variation, we would recover a bounty in wasted resources that would dwarf the puny rewards of cost containment today. Dr. Berwick said this 20 years ago. How far have we not come? As my last slide, I'm going to show you the reference to that, and that would be the second task I could give you for Tuesday. It's a brilliant article, it's a joy to read, and that will be the final slide that I'll leave up. Before I thank you and leave you in earnest, I want to assure you that no children were actually pooped on during the making of this presentation. So I thank you again for having me. It has been such a treat to be here with you. Thank you.